Hello, and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Jennifer Blanchett. Today's episode is part 4 of a 12-part series entitled COVID-19 Answering the Questions. This series features brief updates on the latest incidents and clinical data related to COVID-19 prevention, diagnosis, and management, each followed by an in-depth question and answer session designed to address infectious disease specialists' most pressing COVID-19 questions. During this episode, Dr. Vikram Mukherjee from New York City provides an update on the latest COVID-19 incidence trends and a concise summary of updates to the U.S. National Institutes of Health and the Infectious Diseases Society of America recommendations for managing COVID-19. For more information on Dr. Mukherjee and for a link to additional online education from CCO's COVID-19 Comprehensive Resource Center, please visit the show notes for this episode. Now let's get started and hear a brief COVID-19 update and answers to clinician questions from Dr. Mukherjee.
Thank you, Jen. Good morning or afternoon, everybody. Good afternoon or morning, everybody. My name is Dr. Mukherjee. I'm an intensive care physician based out of New York City, and thank you for coming. I'd like to give you a status update and a brief review of evolving literature on this pandemic. But we would also like to reserve most of this session towards answering some questions. I know there are some pretty compelling questions coming in. So starting with the status update, as of yesterday evening, as you probably know, the global confirmed cases are close to 12 million. In the US itself, the number this morning has crossed 3 million, with Brazil and India having a rapid exponential uptick in the number of cases they're seeing. The deaths continue to worsen to horrific numbers as well. We're looking at a disease that has caused, in just about 8 months, more than 500,000 global deaths, including 130,000 and more US deaths. Brazil, UK, Italy, all making of substantial numbers in terms of the number of mortalities they have seen. Recovery is there, of course. Globally, 6.5 million or so have recovered, including 1 million in the US and just above 1 million in Brazil. But this is, in my opinion, nowhere close to ending. And these numbers, especially the cases and the deaths, will continue to worsen as the months go by. These are some representative graphs on those numbers that we just spoke about. I'll first allude to this orange graph here, the orange curve here. As you can see, a slow uptake and then a rapid rise through April. This is where New York City saw its peak, April and early May. And then we're seeing a horrific rise in numbers in certain parts of the United States, mostly in Florida, Texas, Phoenix, South California. And we're looking at close to 50 to 60,000 cases every day. Other countries are also having very significant upticks in their numbers. You can see here in the red is India, which is looking at 25 to 30,000 cases a day. And in green is Brazil, which is also seeing a significant amount of cases on a daily basis. Moving on to a few points of evolving data that have come up over the last month or so. I think one of the most compelling discussions we've had is on the role of steroids, specifically dexamethasone, used in severe COVID-19. This stems from a very well-run NHS trial from the UK, which looked at around 6,000 patients in a randomized, controlled, open-label adaptive platform trial. And the fact that they were able to carry this out within less than 100 days of developing the protocol is really commendable. They had 4,000 odd patients in the standard care and 2,000 odd patients in the arm that received dexamethasone. And as you can see in this graph, there is a benefit in mortality in patients who are receiving oxygen, who were invasively mechanically ventilated, and an overall improvement in mortality. One death prevented by treatment of 8 patients who are intubated and around 25 patients requiring oxygen alone. And this is compelling data. And we'll talk about this a little bit more in terms of guidelines, but this has impressed a lot of professional societies to include dexamethasone in their management guidelines for severe COVID-19. So, for example, here we see the NIH, National Institute of Health, and the IDSA, the Infectious Disease Society of America, COVID-19 guidelines, which have been updated to include dexamethasone for severe disease. And severe disease is defined by patients who are hypoxic, less than 94%, or those are requiring supplemental oxygen, non-invasive or invasive mechanical ventilation, or the need for ECMO. As you can see here on the left, the NIH now recommends that the dexamethasone at particular dose be used in patients who are mechanically ventilated and who are requiring supplemental oxygen. And it recommends against using dexamethasone in patients who do not require supplemental oxygen, given, as you can see in the first row here, that there was no benefit to a possible signal of harm in patients who are not hypoxic. The IDSA guidelines are pretty similar. And it mentions that for hospitalized patients with severe COVID-19, the panel recommends glucocorticoids in this particular dose. And in patients without hypoxia, again, they suggest against the use of glucocorticoids. And this is in context because, as you probably know, in MERS and the SARS-CoV-1 in the past, steroids had a signal towards harm in terms of delayed viral clearance, more length of hospitalizations and so forth. So that's the background for why there is a little bit of hesitancy in using it in patients who do not have a clear benefit from the recovery trial. Going outside the US, the WHO guidelines are still being updated. And as you can see here from the WHO website, the organization is in the process of updating treatment guidelines to include dexamethasone or other steroids. I'm going to end there, and that's intentional because I would like to honor most of your questions and have enough time to do so. So this is the time where, Jen, I'll hand it over to you to help me moderate the questions.
Great. Thank you so much, Dr. Mukherjee. We're going to start. We've got a couple questions. We'll start with, we've got a lot of questions, but we've got a set on screening. So we'll start there. The first one is, how soon after an exposure will a nasal swab be positive? And sort of tied with that question is, on what day post-exposure is it ideal to do the screening? So we'll start there.
Okay. Wonderful. Thank you, Jen. So the question is, how many days after exposure do you turn positive in testing? I think there are many nuances to this question. So we know from data is that the incubation period, that is the day from exposure to disease onset, can range between 2 and 14 days, but the median is around 5 days. So God forbid if a patient is exposed to an infected individual, he or she may get the infection at a median of around 5 days. And that's when you would start seeing a nasal swab being positive.
Great. Okay, now we have a question from Cynthia. Asymptomatic carriers who are socially responsible have asked for guidance on safely venturing out into the community. Could you share any available guidance regarding asymptomatic carriers?
Yes, absolutely. And this is a challenge because we know from evolving data that around 20 to 25% of infected patients will be asymptomatic, and there is really no good way of knowing, especially in a place like the US and Brazil and India, whether you really have an infection or not. Social responsibility is key here, and wearing a mask. We should clarify that the mask is for source control. If I wear a mask and I'm infected, my chance of giving that infection to a neighbor is lower. And that's the primary utility of a mask. That's going to be key. You should try to keep away from at least 6 feet away from people around you. And lastly, hand hygiene. Basic infection control practices are absolutely the basic maneuvers that you should do. I would suggest that if you are exposed and you think you have an asymptomatic infection, you should be isolating for at least 14 days. And by isolation basically being 6 feet away from anybody, staying away from patients who are high risk of getting an infection, such as elderly patients, immunocompromised patients, and wearing a mask as much as you can.
Great. Okay. Andrea has a question. Should all positive patients be retested until they are negative? And if negative, are they still contagious?
Andrew, that's a great question. Thank you. So our institutional protocols is that we retest at 21 days. So there has to be a couple of things, So suppose I get infected today. I should probably get better within the next 2 weeks. It's at the end of the day a viral illness with a lot of systemic sequelae. But at 21 days, if I were to test myself and there's no complications and I'm clinically improving, I should test negative. So our institutional protocols are that if I am positive today, 21 days after turning positive, I would be retested as long as I'm clinically improving. And I would require 2 negative tests to define that I'm clear. So clinical improvement, 21 days post retesting, and at least 2 negatives to make sure that the false negative part is taken care of.
Great. Okay. The next one is, what are the known modes of transmission of COVID-19 so far?
So definitely, so there's a big question about how airborne this is. As you probably know, there's a huge group of scientists who are urging the WHO to define this as an airborne illness. And by airborne, as you know, it means that the infection can last in the environment, in the atmosphere for prolonged amounts of time. We know for sure it's a droplet infection, and it can transmit by fomites. Data has shown that you can have COVID viral loads in your blood, in bodily fluids, in your stool, but whether that is a potent mode of transmission has not been tested yet. So most definitely droplet, probably airborne. We don't quite know that even if our stool and urine and semen have COVID virus in them, whether that is a route of transmission or not.
Okay. Great. Okay. The next question is about signs and symptoms in infants and children. So the question is, are there studies that show the occurrence of different signs and symptoms in infants and children, and specifically asking about rash and abdominal symptoms? And are the symptoms different in infants and children?
Yeah, that's a great question too. And literature about that is rapidly evolving. We know that kids, in general, the pediatric population present very differently compared to the adult population. There is a much higher incidence of asymptomatic or pre-symptomatic infections in children. We know that they don't do, thankfully, as badly as adults. We know from the Chinese and from the US data that children are not that likely to die of COVID infection as an adult, or more so an elderly patient. And they can have very atypical presentations of what's a conventional viral pneumonia. So abdominal distress for sure, abdominal pain for sure. And then, especially in New York, we are seeing a lot of patients with this entity called MISC, multi-system inflammatory syndrome of children, which is essentially a vasculitis presenting with cardiac involvement, with abdominal involvement. The pathophysiology of that is still being understood, but it has something to do with the ACE2 inhibitors. So yes, the presentation in children and young adults, for that matter, can be very different. If we expect them to always present with pneumonia, which is what we would expect a viral coronavirus to do, we will be missing a lot of cases.
Right. Okay, great. Okay, we'll move now into some management questions. And so the first one is, a person asks, they're in an outpatient-based clinic. So they're in a sick clinic where everyone coming in is either COVID positive or under investigation for COVID. And the patient asks if you could spend some time on any strategies for early treatment. For example, are there antivirals, steroid supplements, empiric antibiotics for lower tract findings? Any tools for sort of outpatient management that have worked?
Thanks. And I think that's a great question. And I think this question came from Arizona, right?
Mm-hmm.
So just as a preface, guys, I hope you're doing okay. My understanding is you're seeing a level of surge that New York City saw in March and April, and I wish you all the best through this time of crisis. If you are working in an outpatient clinic, please assume that everybody coming to your clinic is infected. And I'm sure you're doing that, but make sure you have hand hygiene stations and masks and social distancing available in your emergency rooms and your amp care, we learned here that those can easily act as amplification zones where there is a close cohort of patients coming in to seek help. To your question though, unfortunately, all the data and there is essentially two major drugs that have been evidence proven to have any benefit in COVID-19. Both of them have been tested in hospitalized patients who are hypoxic. So both the trials surrounding remdesivir, which was trialed in patients who were hospitalized and had hypoxia, and in dexamethasone, which was also in patients who were hospitalized with or without hypoxia, were done in patients who were not outpatients. So right now, there really is no data to suggest that outpatient management can be of much help. That said, if they do not need hospitalization, they should go home with close follow-up of their pulse ox. We know that the maximum deterioration can happen in week 1.5 or to 10 days. So please be aware that they can report back to the ED if they go home on self-monitoring and fever checks.
So the next question then is, what is the treatment strategy of COVID-19 negative PCR? So the patient tested negative, but they have clinical signs of pneumonia, and they have a history of close contact with a patient who was COVID positive.
Wonderful. So it depends a little bit on which part of the world you're in. But if you're in any place that has a huge prevalence, and that includes essentially most parts of the world, be it the US, be it parts of Latin America or Southeast Asia, you should be treating any patient with a pneumonia as a COVID pneumonia. Testing at that point is irrelevant, just because the community transmission and the community prevalence of this disease is such that the chances of a person coming in with a pneumonia, it's most likely going to be COVID pneumonia with or without a bacterial superinfection. In that setting, do not, like I was mentioning, do not trust a negative PCR. We've had patients here in early March that have been PCR 3 times, 4 times negative. Isolation's been discontinued, nosocomial transmission may have happened, and then the 4th or 5th PCR came back positive. We know from Singapore back in February that the same patient can go from positive to negative to positive to negative. So testing at that point, when you have a pandemic of this scale, essentially becomes inconsequential. You should be treating every pneumonia as if it's a COVID pneumonia, even if your testing is negative.
Great, thank you. Okay, the next question is, at what stage for decision-making should dexamethasone be prescribed to hypoxemic patients? So how's that decision tree?
Oh, that's a great question. And this comes pretty fresh off the press from the recovery trial that we were mentioning here. So essentially what the data shows is that if you have a hospitalized patient who is intubated, there looks like there's a benefit from using dexamethasone, and that looks like it's a class effect, not just dexamethasone, but those benefits should extend to prednisone and hydrocodone and so forth. If you are hospitalized and hypoxic, there seems to be a benefit to dexamethasone, but not in the same amount of benefit that you would see in a patient who's intubated. And just to keep in context, dexamethasone has been studied not only in COVID ARDS, but also in pre-COVID acute respiratory distress syndrome. So essentially any acute respiratory distress syndrome, if you use dexamethasone in the fibrotic or the fibroproliferative phase, it seems to have a benefit towards improving outcomes. So for COVID specifically, consider using it in patients who are intubated, and also consider using it in patients who are in your hospital hypoxic, less than 94%.
Okay. And then I think you touched on this briefly. Someone asks about equivalent doses of dexamethasone to other glucocorticoids. So do other corticosteroids such as prednisolone, are they likely to be effective, or is it no?
Probably. That becomes an interesting question, because I'm sure that we are going to run out of dexamethasone if this pandemic continues to blossom the way it is. And then the question is, should you be comfortable using prednisone or hydrocod or solumedrol and so forth? It looks like it's a class effect. You should be okay using it. There is nothing specific about dexamethasone, at least in theory, that the other steroids do not offer as well. Of course, Dexamethasone has less to do with fluid and water retention that may have a benefit, but overall, there's not a huge amount of differences that dexamethasone will offer in terms of uniqueness compared to other steroids. So yes, if your hospital is running out of dexamethasone, you should consider using one of the other steroids such as prednisone or Solumetrol or hydrocortisone in a dose-adjusted regimen.
Okay. A question from Ketchy asks, in terms of the dose duration of dexamethasone, they believe a 10-day use is what's recommended. If the patient still has hypoxemia after 10 days, do you continue use?
No, I would stop it. Dexamethasone at the end of the day is a double-edged sword. Steroids, as you probably know, has a significant side effect profile, including hyperglycemia, including ICU delirium. We see that a lot of it in the ICU. It has a significant amount of neuromuscular weakness in your ICU populations. And overall, since the data is there for 10 days, I wouldn't extend its use. It can make you immunocompromised, and fungemia, secondary bacterial infections, those can cause consequences down the line. So I wouldn't use it more than what has been studied so far.
Mm-hmm. That's a really good point. Great. Okay, so someone asks about, given the data that we have on dexamethasone now and remdesivir, do you envision or in your practice, have you seen any use of the combination? And do you think there may be benefit there?
Yeah, yes, I think we would. I think they serve two different targets. Remdesivir, as you know, is an antiviral, and dexamethasone obviously is an immunomodulator. The way I would personally approach is that if a patient comes in early in the course of disease and is viremic, remdesivir would have a much bigger effect in being able to suppress the viral load. Steroids in that setting might actually be dangerous, and we know that from other coronavirus data from MERS and SARS-CoV-1 that steroids, if used within the first week of the disease, when there is still viral replication and you need the host immune system, can worsen outcomes. Steroids become more useful in the second phase of the disease when there's no longer viremia, but there's aggressive host immune response. And that's a consequential dysregulation which steroids can hope to quieten and lessen the effect of that. So I think both of them have a role in different time phases of the disease, one to address the acute viremia, one to address the host immune system, which goes rampant in this setting.
Great. The next question is, do you have any idea of the long-term health complications in people who have recovered from COVID-19?
Yeah, that's great. That's a great question too. And thank you. These are very compelling questions. Most of the long-term consequences are still developing. At the end of the day, this is still a novel virus that humanity has seen for just around 8 months. So some of these questions are unanswered, but I'll tell you what we have seen from the ICU perspective. The survivors of COVID ARDS who have, somehow made it over their acute phase of illness, a significant number of them have been left with horrible sequelae of critical illness from COVID. They've been left with renal failure. They've been left with significant fibrotic lung disease requiring weeks to months of mechanical ventilation. And that's just the physical toll. Neurological manifestations are key. And besides this, the amount of stress and both emotionally and financially that this causes on their families and their livelihood is unspoken and is of a consequence that we can't even imagine right now. So yes, most of this is developing, but for survivors of COVID, especially the ICU survivors, the sequelae of this is going to last for months to years.
Okay. The next question, I think it's from Princewell, asked, does having antibodies for COVID-19, meaning that one has had a prior infection, also mean one cannot transmit? Simply put, is there no chance that the antibody prevents one from developing symptoms, but then you could still get the virus again and then be infectious to someone else? It's a kind of complicated question, but I think
it's a good question about antibodies, because a lot of people have a lot of maybe not misconceptions, but early conceptions about how antibodies play a role. So yes, if you have antibodies, it means that you've had an infection. That's for sure. What it doesn't quite tell you is that how long those antibodies work and will last in your system, what consequences it will have on your immunity to a second exposure, and B, whether it will diminish your clinical features if you had a second infection. So on each of these, a recent trial came out of Spain from which, as you remember, in February or early March was the center of a lot of COVID infections. They found that within a few months of developing antibodies, a lot of the patients did not have antibodies anymore. So the first point is that we don't know if it gives you immunity at all, having a previous infection. And even if it does, we do not know how long that immunity lasts. The second question is whether you would have an atypical or a milder form of disease. Again, I don't think we know that yet. I would hate to offer you, guidance or statements that don't have evidence behind them. And unfortunately, so far, we don't know that patients who've had antibodies get a milder form of the disease.
Right. Have you seen any cases of reinfection or relapse in your setting?
Yeah, healthcare workers mostly.
Okay. So that leads into, do you suspect it's relapse, or I guess it may not be known whether it's reinfection?
Yeah, I don't think I do remember that we had a lot of false confidence, when we were testing antibodies in our crew. A few of them, showed that they had antibodies and were of the mindset that we don't need PPE anymore. And it took a fair amount of education to correct that misconception locally, saying that antibodies are there, sure, what it's worth, how long they last, but we really don't know.
Okay, great. So the next question is from Joe asking, what has been your institution or other hospitals' rate of healthcare provider infection? This is related to that as exposure has increased. And I guess, you've kind of already answered the second part of this question, was whether there's been any information regarding post-infection immunity among healthcare providers with antibody titers. And and is there any perceived protective effects being reported by healthcare providers?
Perception, yes, but I would say that's a misperception. To your first question about what the rate is, we don't have actual numbers, but I can say that a lot of my colleagues had URI symptoms in the middle of our when we were the epicenter of the pandemic. A lot of our colleagues tested positive as well. It's very difficult to say whether they got infected from the healthcare setting or from the community, just because there was rapid community transmission going on as well. When we tested antibodies, it was kind of curious to find that healthcare workers had a lower rate of antibodies than patients who had no contact with the healthcare facilities. Again, very hypothesis generating at best, whether the PPE you're wearing protects you and you're in the community and you're not as worried, therefore you're more prone to be infected. All those are hypothesis generating. But yes, healthcare workers definitely are a high risk group in terms of nosocomial transmission.
So the next question is a patient with moderate COVID infection 3 months ago, no hospitalization, has a persistent cough and occasional shortness of breath, chest x-ray is negative. When should further investigations be done?
So that's going to be a little bit case by case. I wouldn't be surprised if someone who has horrible lung disease from COVID has a residual cough 2 to 3 months out. But there should be if the patient is febrile, for sure, if the patient is developing worsening shortness of breath, if there's mucopurulence to the cough, or if the cough is worsening, those are definite times when the patient should seek medical help. But if it's just a cough that is improving over time and is 3 months and there's none of the associated features of an active infection, that hypothetical patient should be okay being monitored at home.
Okay, great. Okay, the next question, can an MRI of the chest substitute for a CT to minimize radiation exposure in cases where serial scans are required?
That's a good question. So, 2 points about that. You should not be requiring serial CT scans. It's not going to show you much. maybe you get one a couple of months apart to look at how bad the lung disease is, but really there's not a huge role to play in getting more frequent CT scans. If you had to get one to look for a PE, God forbid, or to look for complicated pneumonia, you should still get a CT and maybe use an ultrasound, point of care ultrasound to help. MRIs in the pre-COVID literature have been quite humbling in chest radiology. There is a high incidence of inter-observer radiology, interpretation. For example, the same chest radiologist, if you compare the same MRI images to between 3 or 4 chest radiologists, they'll come up with different interpretations, which is why in COVID or non-COVID data, MRI doesn't really have a huge role to play in chest imaging.
Okay, great. Okay, we have some follow-up questions. A couple people are asking for clarification on your experience with healthcare workers. Did they have relapse or second infection? And they're wondering about the time frame between those two.
So, a good question. And, I just tried to explain what I was saying earlier. Mm-hmm. These are anecdotal patients or healthcare workers, so I wouldn't use this as hard science. Mm-hmm. But yes, we've had healthcare workers who got infected, tested positive, were well for 2 to 3 weeks, and then had another episode of fever, URI, and PCR positive. Now, a couple of caveats. We don't know if that PCR positive was the same PCR from early on. This was a slow improvement, whether there was a second infection or a relapse. So we don't have that data yet. But yes, we have had physicians and nurses who've had 2 discrete episodes of viral URI and have tested positive both times.
Next question from Ballhofer. What would you recommend in a case of COVID-19 pneumonia that has clinically resolved, but the chest X-ray demonstrates persistent infiltrate?
So that's a good question. So if you have clinical improvement, and by that I mean that fevers disappeared, symptoms have improved, shortness of breath and other symptoms improved, the COVID X-ray can take weeks to months to completely resolve. And if you have a severe enough disease, it might never resolve and can have a end-stage lung disease fibrotic pattern. So clinical over imaging, if you're clinically improving and you have 2 negative PCRs, then you should be reassured that this chest X-ray is just a sequelae of prior infection. Other things to consider, of course, is bacterial superinfection on a viral pneumonia and the fibrotic ARDS thing that we were discussing earlier.
Thank you very much, Dr. Mukherjee, and thanks to listeners for joining in. As a reminder, to view the COVID-19 Comprehensive Resource Center on the Clinical Care Options website, click on the link in the show notes. Please be sure to check back regularly for more episodes on important infectious disease topics. Thanks.